Cancer Center that will be discussed in 5 minutes, the results of the LBA-8.
Thank you, Dr. Passaro, and thank you for being here so early. And these are my slides. I'm going to present later on the phase 3 COSMIC-313. This is the first study with a modern control of here, cabozantinib, nivolumab, ipilimumab versus nivolumab and ipilimumab. These are my disclosures. And overall, as a way of background, we know that dual checkpoint inhibition with nivolumab, ipilimumab has been for some while a standard of care for first-line advanced RCC in IMDC intermediate and poor risk, which around 75 to 80% of all patients with metastatic RCC. Cabozantinib is a multi-targeted tyrosine kinase inhibitor, which is a standard of care as a single agent frontline or in combination with nivolumab. COSMIC-313 evaluate the triplet of cabo-nivo-ipi versus placebo-nivo-ipi in untreated patients, as we said, with metastatic RCC of intermediate and poor risk. And this is the study design. No prior systemic therapy. You have to have advanced RCC and clear cell component. That's over 80% of patients of intermediate and poor risk. And then you get randomized to nivolumab, ipilimumab at the standard dose we use in renal cell cancer with low dose ipi of 1 mg per kg, plus placebo or plus cabozantinib. The primary endpoint is progression-free survival by blinded independent center review, and your typical secondary endpoints of overall survival, response rate, safety, and duration of response. And this is actually the slide. I think this is the primary endpoint, the most important slide here, the progression-free survival. The study met its primary endpoint of PFS. The hazard ratio was 0.73. That's 27% decrease in the risk of progression or death. On the triplet, the median PFS was not reached, and on the doublet was 11.3 months. In terms of response rate, these are confirmed objective response rate. They were numerically higher with the triplet, 43%, versus the doublet, which was 36%. Interesting enough, we looked specifically at the intermediate versus the poor. 75% of patients enrolled on COSMIC-313 were intermediate risk per the IMDC criteria, 25% poor risk. It seems that the benefit here, mostly at least, is in intermediate risk patient. The hazard ratio for the whole population is 0.73, and it goes down to 0.63 for intermediate risk. Even the responses differences are wider, 35 versus 45%. In poor risk, the hazard ratio for PFS is 1. It doesn't seem that there is a difference, and the response rate are similar, around 37%. So we conclude that the study, COSMIC-313, is a positive study. The primary endpoint was met. It is PFS, and the triplet of cabo-nivo-ipi does prolong in a statistically significant and clinically meaningful way PFS compared to nivo-ipi alone, nivo-ipi and placebo. Again, the population is metastatic RCC with intermediate or poor risk. We found a greater benefit in intermediate risk. The responses were numerically higher. The safety in general, I didn't show you, was generally manageable, consistent with the profile of the treatment component. We had 3 in particular to highlight that were more in the triplet. LFTs increase, diarrhea, as well as skin toxicity. And importantly, follow-up for the secondary endpoint of OS is ongoing. Thank you.
Thank you. Thank you.